it was such a great success and a great honor to attend the meeting. I only regret that I was not able to be there till the end because I had agreed and promised Dr. Sartorius that I will return with him because he's a little, apprehensive about traveling within India after the COVID. So I came with him and went back with him. Otherwise, I would have stayed till the end of the conference. But from all
chairman of the program, chairman of the ANSIPS recently organized. Sir, over to you.
Thank you, Alim. And it's quite satisfying to have concluded the ANSIPS. We are satisfied. And if there is any mistake, it has been inadvertent. Welcome back to Thursday Musing 128th episode. I am introducing our stalwart moderators, Dr. Alim, who is speaking, and Dr. Amilpat Joshi, who is here on the screen. And both are leading members of Indian Psychiatric Society, Office Bearers, and Executive Committee. Both are Professor of Psychiatry. Next, please. Yes, it is Alim Siddiqui from Lucknow. And now I have the job to introduce our speaker, chairpersons. Next, please. Dr. Vibhu Kalyan Shahu, who has reported to me that there is some problem in the hospital. He will be joining, say, within half an hour. He is assistant professor in Department of Psychiatry, MKC Medical College, Berhampur. Works as nodal officer for implementation of DMHP and De-Addiction Center. Nodal officer of Tridimanas Cell, MKCG. One of the semi-finalists in National Scotch Award. And member of Mental Health Review Board, Ganjam. Led the foundation of DMHP units in district Ganjam, Kandhamal, Gajapati, and Malkangiri. Has 5 publications to its credit in national journals. We will welcome when he joins. And Dr. Jannavi Kedare, next slide, please. Welcome, Dr. Jannavi Kedare. I am from Mumbai. Currently, she is additional professor, Department of Psychiatry, TNFC, and BOER, Nair Hospital, Mumbai. More than 25 years of clinical experience. Areas of interest: genetic psychiatry, community psychiatry, ethics in research. Current positions: President, Prevention of Sexual Harassment Committee, TNMC. Convener, Clinical Practice Guidelines Subcommittees, IPS. Chairperson, Award Committee, ISGMH. Member, Institutional Ethics Committee, TN Medical College. Positions held: past President, Bombay Psychiatric Society. Past Honorary Secretary, Indian Association of Geriatric Mental Health. Past Honorary Secretary, Bombay Psychiatric Society. And she has 38 publications to her credit. Involved in public awareness through newspaper and magazine articles and radio and TV programs. Welcome, Dr. Kedare. Now the further proceedings is up to you. Please carry on. And Dr. Shah will be joining you in time. Please carry on.
Sure. First of all, at the outset, let me thank Dr. Tufan Pati, Alim Siddiqui, and Amilpat Joshi for giving me this opportunity to chair this session. And Thursday Musing has been one of the consistent platforms of academic activity since COVID, and I think it will continue doing so forever, looks like, because we are back again with a bang and with a very renowned speaker this time, Dr. Debashish Basu. It gives me great pleasure in introducing Dr. Basu, a very well-known personality, especially in de-addiction psychiatry, in social psychiatry, and in public mental health. He is at present Professor and Head, Department of Psychiatry, PGI Chandigarh. He has been in PGI Chandigarh since 1993, and from the rank of Assistant Professor has reached the rank of Head and Professor since 2008. He is the head of the department in 2021. Number of projects which he has carried out are more than 50, and publications are 400, more than 400 publications and more than 20 book chapters. You can see the citation indexing and imagine the kind of impact his articles have on the fraternity. He has won a number of awards. Few of them are Nida Invest International Research Fellowship, NHS International Fellowship, Honorary Fellow World Association of Social Psychiatry, Tilak Venkoba Rao Marfatia, Bhagwat, PPA, IPS, Ballant, you name it, and he has bagged that award. At present, he is the President-elect, Indian Association for Social Psychiatry. I think one of the important things that have happened since he has become the head of the department is that PGI Chandigarh has become the WPA Collaborating Center for Public Mental Health Program, and I'm sure he plans to do a lot of work related to public mental health through the Collaborating Center, especially policy matters, propagating mental health, promotional activities in the community, creating community awareness, and so on and so forth, mainly towards prevention of mental disorders, I'm sure. We are all so keen to listen to you, Dr. Basu, and so without wasting any more time, I hand over to you, Dr. Basu.
Yeah, thank you. Thank you very much, madam. May I start? Thank you for those lovely words. It's always nice to see good words about oneself, even at this age. Can I share my screen now? Yes. Yeah. Right. Okay. Thanks to all. Thanks to madam. Thanks to the organizers. It's a great pleasure to be here, and especially after the ANSIPS, which I missed. There have been some little bit of health issues here and there, so I've been trying to minimize my travel. Anyway, so here we are. Let's start without any further ado. It's 8:15 p.m. in Indian time now here, and I'll need about 45 minutes if you allow me.
Sir, I'm sorry to interrupt you. Can you go on the slideshow?
Oh, yes, I will. Yeah, is that all right, madam, now?
Yes, it is.
Right.
Yeah, thank you.
So without any further ado, as I was saying that I have about, I'll take about 45 minutes or so to cover this very vast topic. And I was trying to cut down the number of slides till the last moment. But anyway, now, when I took a lecture, a class to my students in PGI very recently on something related to that, on our public mental health, I said that please be prepared for a very boring lecture. A very boring lecture. It was 8 o'clock in the morning. The young students, the junior residents were coming, they were trying to suppress their yawns, obviously. And I said that, okay, that was the first talk on community mental health. So I said that, okay, this is not something which we normally talk about. You see, as doctors, as psychiatrists, as mental health specialists, we do not talk about something called public mental health very commonly. We do talk about community psychiatry when we going to a specific place and setting up a satellite center or a clinic in a hospital, those kind of things, or helping the primary care persons, which is all very good. I'm not trying to belittle that. But what we are today going to talk about is something vastly larger, broader, and with its own challenges. And at times, we'll feel that we are going out of our depth and out of our breadth. So with that caveat, with that challenge, let's open this. The first, as you can see, this is called a follow-on public offering. Some of you who keenly observe Indian politics and the recent happenings, I don't want to take names and etc., should be familiar with this thing called FPO, or follow-on public offering, which a famous industrialist of India had offered and was almost going down the drain, then got fully subscribed. And that same evening, he decided to take it away again. So I'm not going there, but that is what is a follow-on public offering. This started from an initial public offering, a talk which I gave in this place called R.G. Kar Medical College and Hospital. It's a very interesting and very important college in Calcutta. We'll come to that in a second. This was done, this talk, the initial public offering talk was given on 10th of June 2022, about 8 months from now, and was presented there as the first opening up of this what I felt was a talk from our side. So what is an IPO, an initial public offering? Again, people who are dealing with, a disclaimer, I don't deal with shares and stocks. I used to at one time, but I realized I was not meant for it. So I stopped everything, and I only put my money in public provident fund now. And now the government says I can't put in more than 5 lakhs. So it's very sad. They're forcing me to go to mutual funds, which I don't want to. But an IPO, or an initial public offering, is when a private company first sells shares of stock to the public. This process is known as the IPO, when it first opens up, okay? In a sense, an IPO means that a company's ownership is transitioning from private ownership to public ownership. And that's important, because I felt that it's time to go public with public mental health. We'll come to the meaning of this follow-on public mental health, so follow-on public offer, the FPO, at the very end of the talk. Knowingly, I've kept it at the very, very, very end, the last 3 slides. We'll come back to that. So hold on till such time. This was a direct, as Madam Dr. Janhavi Kedar has already mentioned, that this was a fallout of the WPA collaboration center status given to PGI Chandigarh. We are very grateful to the WPA for that. In April 2022 by the World Psychiatric Association. And as you can see in that letter by Dr. Afzal Javed, is that WPA would like your collaborating center taking a priority for public mental health, etc. That was the mandate. So in a manner of speaking, I'm kind of following up on that mandate now. Before we go any further, I'd like to very clearly, when you search in the Google or Google Scholar or PubMed for public mental health, you'd be amazed to find actually citations going up to 100 years ago. So you'd wonder that what is so new about it? That's because the public mental health has two very different connotations, similar, related, but very different. The first and the long-lasting from 1900s onwards is actually about public mental health system. Okay, systems which serve the public. So these are the public mental health systems which have been there for for a long time. System, services, program. These are basically government funded, hence public, as opposed to private, not for profit mental health care facilities, as opposed to private, corporate, or for profit systems. Historically, these were the mental asylums, and that's why it goes to a century ago, right? Typically, these are mental health institutes like CIP Ranchi, NIMHANS Bangalore, IPAS Delhi, or later the original ones, mental asylums to mental health institutes to general hospital psychiatric units, the big change, GHPUs. And the first in India was Carmichael Medical College in 1933, which was exactly 90 years from today. 90 years from today. And my dear friends, the Carmichael Medical College is none other than the RG Kar, the Radha Gobindo Kaur Medical College, where I gave this talk to my student and dear friend, Dr. Rajesh Yogi, who had organized that. So it was amazing that Carmichael Medical College, Radha Gobindo Kaur was it, and it was started by none other than, by the way, just as a historical aside, allow me this 1 second of fun, was none other than by Girindra Shekhar Bose, G.S. Bose. Yes, the same G.S. Bose of the famous Bose-Freud correspondence in psychodynamics, psychoanalysis, but he was also very much into this. He started the first psychiatric clinic, which was unheard of at that time, 90 years ago, because people were quote unquote mad people and they were put away into asylums. Anyway, that's a different story. So, and now of course we have moved on from there to psychiatric OPD facilities only of hospital or clinic based, where they're only the outpatients, and finally even going into community or non-hospital based facilities. It's a kind of all public mental systems. Essentially, The two characteristics are that it serves the public and is publicly funded. But there were major issues with all these things. As we all know, there's nothing new about that. These were often underserved, under-resourced. They looked at the individual and not at the greater picture. You know, a patient coming to you, that's what we do, don't we? Every day, day in, day out, we see look at the patient, we write a particular medication or a couple of medications, we say a few things and the patient goes. It looks at people who are already fairly advanced in the course of their mental illness. At times, I mean, in PGI or in NIMHANS or any of the places, Dr. Mona Isaac is there, and there's so many, of course, Dr. Khandelwal is there. I'm really overwhelmed to have them in the audience today. We have seen that in bipolar disorder, the median time of coming to our help is about at least 10 years, usually 15 years. You know, they'll ask them, why are you here? So they didn't know. Or didn't know that there's something available. These are focused more on pharmacotherapies or physical therapies like ECT. Due to the circumstances, you can't help it, right? When you have 200 patients waiting outside your OPD, you don't talk about many things. These are focused on illness, not wellness. So there's a very tacit assumption, which I'm going to challenge very soon, is that absence of illness is tacitly equated with wellness. कोई problem नहीं है, allow me a little bit of Hindi there, कोई problem नहीं है, इसका मतलब सब कुछ ठीक है. In Punjabi, सब कुछ चंगा है. You know, everything is fine. Just because there's no diagnosable ICD-10 and now ICD-11 illness. No. And hence, no focus on prevention of mental illness and promotion of mental health. They are kind of, you know, they take a back seat, obviously. From there, my friends, we come to public mental health, the broader meaning. So it was necessary to talk about the public mental health systems which exist. They're, well, of course, they serve the public and they're publicly funded. So they're tremendously useful. There's no question of substituting them, but they have their issues and their limitations. From there, we come to public mental health and the broader meaning of that. The broader meaning of public mental is not about system or hospitals. It's actually an approach, or some would say a paradigm, which is basically a way of looking at, you know, a perspective, a way of looking at things. Even broadly, it's probably a philosophy, a way of thinking. It includes the public mental health services, but it goes far beyond, far beyond. And it incorporates the concepts of public health, the ones which we had read in school as public health and as community medicine, applied to the field of mental health. It incorporates the concept of mental health along with illness. We'll come to it. Incorporates the principles of prevention of illness at various levels. We'll have to spend a few slides on the prevention part because that's so very central to the public mental health concept. However, having said all those previous things, the essential and the central characteristic of PMH, in short, public mental health, is that it's a population approach vis-a-vis an individual patient approach. This is, if there's one thing that characterizes public mental health and distinguishes it from all other kind of mental health approaches, is this, that it's a population approach. It looks at, this is the example which I gave, of course, the classical example in epidemiology and in preventive medicine, etc. When John Snow, the famous, epidemiologist, I think he was a physician, removed the handle of the water pump in Broad Street of London, 1854, which he suspected that water was infected coming out from that pump, that hand pump was infected, but he could not have done that. So at night he went there and chup-chup, very silently, he just removed the handle. He thought that it was causing that cholera epidemic in that part of the Broad Street, London. He did not treat a single patient, you see. He did not treat anybody. But he prevented cholera in the entire local population using that water. That's the ultimate example of, of that public health approach, that you do something which affects the population in a broad manner and in a kind of indirect, but it's so that's John Snow and the thing. And this is the that famous pump on Broad Street, London, maintained till this date. And if you look closely, I mean, that's a girl who is just taking a nice photograph of hers. If you look closely, you see, my dear friends, there is no handle. It's important because we'll come back. I promise you I'll come back to the handle. मैं नहीं छोड़ूंगा handle को. I will come back to it. There is no handle of that. And that's the essence, if you allow me, in a symbolic, in a kind of metaphorical manner, the essence of population health and population mental health as well. So the WHO gave this population, this is what we're talking about. So there are three major components. Mental, it's not just treatment and rehabilitation, which is a major component, but along with that, prevention of mental illness and promotion, going even one step further, promotion of mental health. All these at a population level would make up public mental health. We don't talk about these things. We do not talk about these things. What you cannot, allow me a couple of slides on that. We cannot proceed further without talking about this odd, uncomfortable question called, what is mental health? There are certain things. Once I read somewhere that if you ask someone that what is a spiral, it's so easy, it's so intuitive. What is a spiral? And nobody can define a spiral. Everybody, if you can see me in the side inset figure, I can't see myself, but the spiral is shown like this. If you ask anyone, they'll say, oh, spiral to ye hota hai. It's like this, It's very easy intuitively capture the concept of spiral rather than to define it. Same thing about mental health. It's easy to intuitively think, oh, he's ill. But what is mental health really? Is it just absence of mental illness? No, obviously not. As per WHO, again, it's a state of well-being. It's a state of well-being in which every individual realizes his or her potential, can cope with the normal stresses of life. So coping ability, can work productively and fruitfully, working ability, and is able to make a contribution to his or her community, a contributing ability. WHO 2004, possibly one of the best global. We have, by the way, very nice definitions from Indian psychiatrists like N.C. Surya, which Professor N.N. Vig had talked about, had talked, but we are not going into all those details now. Then it will become a talk on mental health itself. Very nice definition by Surya. And of course, Freud's famous definition, we know, living, loving, working, etc. There is no mention of mental illness or his absence in his definition. This is what is to be noted. Mental illness is conspicuous by its absence in the definition of mental illness. So it's not just the opposite of mental illness. More theoretically, for those who are academically minded, there are two components. One is a feeling happy component, maza, fun, hedonia, feeling happy, positive emotions, which are by definition short-lasting, dynamic. And the other is a more stable feeling of well-being, which people who are more advanced, they say, which is in Greek, the word is eudaimonia, feeling useful and fulfilled, in that it gives that social kind of a feeling, positive functioning, expression, which is long-lasting, stable, contributes to society and community, etc. So, mental health. The point is that, the point I'm trying to make here, and let me make it very explicit now, my dear friends, is that the absence of mental disorder does not necessarily mean the presence of good mental health, and vice versa. I'll show you a very interesting slide later on, where a person with schizophrenia says that I have schizophrenia, but I have mental well-being also. And many of you would know from your patients. I had a long-acting patient, one of the security guards in PGI, Chandigarh, who used to hear voices, but with medications, he would be happy. He would continue to hear occasional voices, but he raised a family, he raised children, his life. Anyway, and the other side is also true. So that's important to understand for public mental health, because public mental health incorporates both illness and wellness, and they are not just opposite of each other. Looked at another way, people living with mental disorder can also achieve good levels or reasonable levels of well-being, living a satisfying, meaningful, contributing life within the constraints of painful, distressing, or debilitating symptoms. This is the famous, very good book, not very well hailed, I don't know why, a very good book of WHO called Social Determinants of Mental Health. And it, interestingly, it refers to the Nobel laureate Amartya Sen, a psychiatric book referring to an economist. Okay, of course, Amartya Sen has talked a lot about happiness and stuff. So mental health and well-being, it says that there has been growing interest in well-being in recent years, those days, almost 10 years now, among researchers and in public policy. Amartya Sen's capability approach, very highly influential has been influential in opening up debate around a set of capabilities that enable individuals to do and to be that which they have reasons to value. According to Sen, the range of things which people value doing or being may vary from simple, quote unquote, quoting Amartya Sen, elementary ones, such as just being adequately nourished and being free from disease, to very complex activities or personal states, such as being able to take part in the life of the community and having self-respect. All of us, despite of whether I have my myopia, my very high myopia, or whether somebody has a medial meniscus tear, or whether somebody has diabetes or schizophrenia, has capabilities. And the focus of one of the focus of public mental health would be to enhance the capabilities and to reduce the liabilities. So something like that. Okay. Again, quoting from that same book, further giving example, mental health is integral to this conceptualization of well-being, because it enables people to do and be things that they have reason to value. This value-based thing is becoming important. It's not just symptom-based approach, whether you hallucinate or whether you are deluded, but that becomes it. Conversely, being and doing things one has reason to value contributes to mental health. And capabilities to do and be are shaped by social, economic, and environmental conditions. Now, there's a simple illustration. A woman's capabilities are severely restricted if she is unable to complete secondary education, is subjected to domestic violence, works for low pay. Mind you, none of these are psychiatric symptoms, are they? No, of course not. Secondary education, domestic violence at home, works for low wage. As you know that females, often women, not just here, but in UK as well, they are paid less. Female secretaries are paid less than male secretaries, right? They used to be till very recently. Works for low pay in the informal labor market and faces difficulties in being able to feed and clothe her children. Now, these are examples of social determinants. Such a woman, as from Brown and Harris and all those, 50 years ago studies have shown, is at higher risk for low mood and feelings of hopelessness and helplessness associated with depression than a man who is not exposed, than a woman who is not exposed to these social determinants. From there, WHO moves on to this very important document of 2013-2030, the Comprehensive Mental Health Action Plan. Very comprehensive book, as the name suggests. Obviously, we are not going into great details about there. Freely available in public domain, obviously, like all WHO things. But the point is, in that structure of that comprehensive mental health plan, we are sitting in the middle of that right now, absolutely in the middle. If you see the point number 21, the overall goal, its overall goal is to promote mental well-being, prevent mental disorders, provide care, enhance recovery, promote human rights, and reduce the mortality, morbidity, and disability for persons with mental disorders. Well, it covers everything. But that is also the ambit of public mental health. And with these objectives, which as you can now see, it's basically about talking about such kind of things here, right? Now is the question for which probably some of you, especially the younger ones, or those, if there are any, or people perhaps in practice or people elsewhere, and including many of us, I don't want to say that I'm holier than thou kind of approach. Obviously, we have started wondering what the heck is a better word than the other one, for parliamentary reasons. What the heck is going on? Why are we talking so much about like, that kind of spirit, that idealistic world thing? My job as a psychiatrist or a mental health professional is diagnosis, treatment, and follow-up. Where does all this come there? Why should I be spending this time like this? Do we also realize that our job as doctors, not just psychiatrists, as any doctor, or as citizens for that matter, broader way, also involves advocacy, spreading awareness, taking part where possible in policy decision. Just 15 minutes before this talk, when Dr. Aleem Siddiqui Aleem Bhai was contacting me regarding this nitty-gritty of how to send whatever, I got a call from the Health Minister of Punjab, he's a doctor. So when Dr. Balbir Singh, the recently appointed Health Minister of Punjab, said, Dr. Saab, oh, chitta is heroin. Okay, so that's a white, chitta is a Punjabi word for white. So that's a white heroin. Overdose deaths ho raha hai, bahut zyada, lots of overdose deaths going on. We need to do something immediately. Can you come? Can we sit tomorrow sometime? But whatever, we need to do a plan. The point was that about plan and policy. Okay, you will say, okay, you are Dr. Basu, you are in addiction psychiatry, you are sitting in, that ivory tower or whatever. But no, not necessarily. That's wrong. Even a single person can have some action in some of these and in liaison, because we are, by virtue of our being doctors, and depending upon how much we are willing to stretch ourselves, a bit going beyond the usual call of the duties, we can definitely, we are very valued members of the society. If we value ourselves, if we have self-respect, I'm sure we are needed. All these require, the last four that I mentioned, all these require a population approach. That is beyond I'm not trying to say that we stop diagnosing, treating, and following up our patients. Even there we can use public mental health approach. I'll come to that in a minute. But before that, this is to my mind, the best and the most comprehensive, again in public domain, fairly recent. This is by Jonathan Campion and other people from Oxford Group, Kamaldeep Bhui, and many other people. Afzal Javed is there. So many of them, it's a combined document of, as you can see, lots of agencies, primarily UK-based, basically UK-based, public mental health evidence, practice, and commissioning, a tremendously, good, as the name says, evidence-based commission, what's required. But I'll just take the definition for now. Now, finally, we come to a formal definition, as it mentions that it takes a public mental health, takes a population approach to mental health, which includes assessment and strategic decisions to improve coverage, outcomes, and coordination of different levels of mental disorder, because you require a lot of people in this. We can't do it alone. You require government agencies, you require non-government NGOs, you require people from other disciplines. You have to be in this together. But the aim is to sustainably improve population mental health through coordinated working with a range of organizations, local communities, and individuals. So I think I'm going to skip some part of this because prevention aspects, most of us, I'm assuming, we know from our community, from our, community medicine and public health days, from MBBS days, so that primary prevention, secondary prevention, tertiary prevention, but these are all applied to mental health now. Promotion of well-being, which essentially talks about living well, working well, aging well. There are issues. Recently, I was in London for the World Congress of Social Psychiatry last month. Dr. Subodh Dave, who is now the Dean Academics of the Royal College of Psychiatrists, we had a chat about certain of these aspects. And he said, Dr. Basu, the problem is that there are too many terms. And at times they kind of overlap, There are overlapping elements: preventive psychiatry, social psychiatry, community psychiatry, mental health, positive mental health, this, that. We need to be more clear about what we are talking about. To my mind, if there's one word that characterizes public mental health, is the word population-based approach about mental health as well as mental illness. And this I just now said, according to the WHO, living well, working well, aging well, taking a life course approach, that's promotion of well-being. And that's promotion. And the prevention of mental disorders is, as we know, the public health framework is a primary, secondary, tertiary prevention. Gordon's framework, I'm shortening these parts because I'm keeping an eye on the clock as well. Gordon's framework is the one that we talk about universal prevention, selective prevention, and indicated prevention, right? The universal and the selective are on population approach, either all whole population, universal, selective is high risk population, indicated is early onset. And the WHO framework, which mixes up these two, which combines these two. So this is primary, secondary, tertiary, and later somebody added primordial prevention as well, which is, you know, reducing the risk factors for appearing in the first place. Gordon's is more, you know, applicable to us by examples. For example, the universal one addressing at the entire and others to reduce alcohol-related harm. Controlling open availability of firearms, and in our case, insecticides, toilet cleaner, etc., to reduce suicide. And school mental health programs in all schools to enhance mental health and resilience. General universal programs. And we'll see that these are the most cost-effective and the best probably, although they only help mental health indirectly, but they help. Selective are the high-risk people, for example, screening for mental health issues in vulnerable or marginalized populations and monitoring pregnant women with prior history of mental health issues. And indicated would be at an individual level who already has developed sub-threshold conditions like early intervention for those at clinically high risk for psychosis or attenuated psychotic symptoms. The WHO would combine these and put the Gordon's, the universal, selective, and indicated under primary prevention itself. Okay. And an overall kind of a picture trying to see from worsening to healthy, you know, universal, as you can see from here, universal to primary prevention, to secondary prevention, when the first episode of psychosis probably is just breaking in, from there the first episode to relapse, and then tertiary prevention when it goes to chronicity, but still trying to reduce the disability. This is well known to us, but it's important to put it in one picture. This is a very important kind of research evidence published in World Psychiatry, as we all know, or most of us know, is the highest rated psychiatric journal in the world, with a crazy kind of an impact factor of, I think it has reached 70 now. It's unthinkable. So there, they had this article last year, preventive psychiatry, and there for young people. And the one which I've highlighted is that the universal public health approaches targeting school climate or social determinants hold the greatest potential for reducing the risk profile of the population as a whole. This is what the research is saying. This is extremely important. And did we know this? At least I did, but not at this kind of a very strong research-based level, that physical exercise, not mental exercise, physical exercise has the most, that reminded me, I've forgotten my walk in the evening today, but well, I'll do it maybe later on. Physical exercise has the most well-documented population level effect on, not surprisingly, physical health, obviously, but also on mental health. Yes, on mental health. And then, of course, target interventions like selective and indicated, they have more mixed results actually. The thing that we normally tend to focus more on because they need more, they need us more, but that's on a much smaller population. It is these simple things like encouraging physical exercise. How many of us tell our patients to actually give a, put it in the prescription, put it as a therapy package, clearly, strongly, as good as prescribing escitalopram or mirtazapine, putting them on the same level? How many of us do that? Well, that's the one that we talked about. There's a bit of an overlap, so please pardon me on that. okay, I think I'm going to skip the social determinants thing. In our context, is stigma, discrimination, disenfranchisement. Many countries, they are not allowed to vote, as you know. Social isolation and loneliness. We'll come to that for a couple of slides, particularly on social isolation and loneliness after this pandemic world, or the post-pandemic world, as they're saying. Homelessness, joblessness. These are all, they are not just result of a mental illness. They are also causes. So it's a vicious cycle. They are also feeding factors, feed forward factors, all these for further, worsening mental illness at a population level. Criminalization in USA, most of the jail is full of people who have taken cannabis, for that matter in India as well, on a couple of occasions. And then they're getting criminalized, and that's not going to help in the long run at a population, at a mass level. We're talking about in terms of lakhs, actually, not hundreds, not thousands, lakhs. And the jails are full. This is what the UK, I learned when I was in UK at that time, some years ago, that they started doing this social prescribing along with prescription. So it's a prescription, but along with the drugs, the medications, you also, the GPs and the psychiatrists are encouraged to do social prescribing, addressing people's needs in a holistic manner, gardening, range of thought. So they have these social care services, etc. Whatever we have, we can also try, provided we have our mind towards this. We normally don't apply our minds towards this. We remain stuck at, venlafaxine or whatever. These are worked example, a small worked example of depression. I wanted to come to this is, as we all know, it's a common mental disorders, etc., etc. The typical treatment we all know is medications, ECT, neuromodulation these days, and of course, individual or group psychotherapies. Fine, well and good. This is what we do in India. But did you know that the following are also important for prevention or management of depression? And these are all evidence-based. Absolutely evidence-based. And things like school meal program for kids. What has got meal has got to do with, treating depression, but yes, it has. Proof is there. I'm not going to, they're articles. Workplace programs for employees, easy repayment loan schemes for heads of families, green spaces, parks, gardens, trees, or blue spaces, lakes, pools for elderly people, employment generation schemes for women, especially those who are being stuck in a kind of domestic abuse situation, addressing intimate partner violence for women, microfinancing schemes for needy people, and regular physical activity for all. How many of us considered these in? This is what the Lancet Commission article last year, extremely important article from Helen Herman, Vikram Patel, and the whole group came out with. It's a very, very big, I think it's a 40-page article, Lancet and WPA Commission article on depression. And Helen Herman would be addressing us, our departmental alumni and students on 6th of March. And later on, we'll publish it in our YouTube channel, as you know, where you have all the Dr. Salman Akhtar's 10-part series, etc. But we'll do that. But a bit of a complex thing. But look at these figure 7, opportunities for the prevention of depression across the life cycle. And look at the setting part, just the middle part. Families, programs targeting the one that we talked about just now, intimate partner violence, prevention of perinatal depression. In schools, school climate, programs to promote school climate and prevent bullying. See, we as psychiatrists, as mental health professionals, can put in our weight wherever asked, in schools, in workplaces. You can just see the headings, neighborhoods and health services, to say that, hey, this is also important. And these are all at the public mental level. Very interestingly, I have just a controversially titled this slide called broad spectrum, quote unquote, antibiotics, because we talk about meropenem and whatever, those things, imipenem, meropenem, huge broad spectrum antibiotics. Broad spectrum of community level actions can actually lead to broad spectrum of community level positive outcomes in a very broad manner. So this is by CDC, the Centers for Disease Control Atlanta, USA. They have talked about this pyramid, they call it high five. So high five is basically health conditions that the high five interventions, so these are health interventions, they can address. And not the details, but look at this. These are the kind of things: early childhood education, something called a clean one diesel bus fleets, climate pollution, reducing climate pollution, public transportation system, etc. Earned income tax practice, water fluoridation, and things like school-based programs to increase physical activity, violence prevention, safe routes, blah, blah, blah. These kind of things, how they help? They help not only anxiety and depression, but this huge range of broad spectrum, as I said, antibiotic, from as anxiety and depression to child abuse and neglect, to dental cavities, to teenage pregnancy, to youth violence. This is what an approach, a broad spectrum of public health. This is the study just a few months ago, actually, in JAMA Psychiatry, a very detailed systematic review of association between physical activity and risk of, I'm focusing on that because this is something which is extremely important, and risk of depression. And it shows, excuse me, it shows, the key point shows that a little bit of physical activity. See, look at this highlighted thing. Adults meeting physical activity recommendations equivalent to 2.5 hours per week, not per day. So it's about 20 minutes per day. Okay. Of brisk walking had lower risk of depression, not of cardiovascular health. That, of course, it has, but also at a lower risk of depression. And a lower, that's the meaning. The meaning of this study is said relatively small doses of physical activity were associated with substantially lower risks of depression. At least I didn't know that this strongly till I read this study in details. Is that all? Is that all well? No, there are problems, there are challenges, there are issues, there are difficulties, you know. So challenges, as Guy Goodwin has written in, again, one of the World Psychiatry articles, is it science or is it more of politics or polemics or, you know, using big words and all? So coming back to John Snow's handle, the handle, I say that there's no handle, and I'll come back to that. I promised you, and now with another 7 minutes to go, I'll try to cover it up. The problems are, the challenges, one might say, that we simply do not have the handle. Unlike cholera, I mean, what I'm trying to say is that how does prevention of cholera differ from prevention of schizophrenia, psychosis, depression, anxiety? We don't know. There is no one handle, right? They're all extremely multifactorial, as we know. So we do not have the handle. What are you going to remove? And there are likely to be too many handles, each with very small effects. Some here, some there, a little bit of this, little bit of that, some genetics, hundreds of genes and hundreds of environmental factors. What are you? Yes. So I'm now playing the devil's advocate. Okay, I'm coming from the other side, because these are the questions which I would anticipate from some of you. That what the heck can we do? We can't do anything. The handle may be too long, because once you're talking about some epigenetic changes, starting from young, maternal deprivation and adverse childhood experiences, some glucocorticoid receptors going haywire here and there, etc., etc. And then the adolescent gets depression when he's 18 years old. The handle is too long. The handle may be too high to approach. And that's a valid point, because many of these things, the policy decisions will depend upon the ministers, the politicians, or at least the bureaucrats. So it may be completely beyond my reach or our reach. So why talk? It may be too high at high places, but then. And the last is, of course, the easiest one. Why the heck should I bother about the handle at all? Forget the handle. Let me just treat the cholera. This is, my friends, what we are doing anyway. This is what we are doing anyway. We are just treating the cholera. But at least it's worth thinking about the handle. So I think we can go on further. There are many other slides, but I think we'd like to let me see how it does. Dr. Aleem or my chairpersons, how much time do you think I have? Another 5 minutes or so? Or
Yes, yes, definitely. I think you can go on.
Very
Yes, yes.
Okay,
Dr.
okay. Thank you.
Devashish, you can go further. No problem. It's interesting.
Okay, maybe around 5-7 minutes. But then let's have. Okay, sir. What this is usually I end in a couple of slides here, but let's see if I can go slightly beyond that. At the end of the day, as I said, let me go back to this favorite slide of mine. Then I love this slide. I've made it, but I'm narcissistically happy with this because I mean this is what I tried to think of. That when John Snow could do it, why this is something like eradicating smallpox. We could eradicate smallpox, but can we eradicate drug abuse? That's another talk. Some other day, I give a very provocative talk called that why this drug-free Punjab, and versus Urta Punjab. How is it different? We can never have a drug-free society, but that's for another talk. Okay, because we don't have these handles, etc. I've just now talked about. Coming from there, that let's not bother about the handle, let me just treat the cholera. From there, I would say that what does the PMH approach? Please understand that public mental health is now not about giving a particular medicine or a particular thing, not even only about physical exercise, because there are so many levels there, huge levels, school levels, college level, multiple level, higher. What does it teach me as a person or us? This is my lessons, okay, what I have learned when I started reading about it. To look beyond what is obvious and present. This is what happened, by the way, when all these decades, centuries, we had been treating gastric ulcer or acidity with what? With, antacids or whatever was available. Till a person came and said, no, there's this bacteria and that seems to be very important. Why don't you give tetracycline? People thought they were mad. This is the same thing which happened to this Hungarian, what was his name? Semmelweis, I think, Semmelweis, who died in the mental asylum finally, who thought in the 16th century that the puerperal fever, the maternal fever, was happening when the people were when the people were coming from a different place and their hands were dirty. So he thought that there's something to do with the pre-germ era, So he thought that why don't they should wash their hands? And people didn't agree, including Pasteur didn't agree, interestingly. And then he started behaving oddly. He became very frustrated. Semmelweis, Hungarian physician, obstetrician, he was put in a mental asylum himself. He died there. And later on, of course, everybody knows that that's the best way in preventive psychiatry, sorry, not psychiatry, in preventive medicine. That's one of the classical examples of hand washing and prevention of so many things, including maternal fever, puerperal fever. So to look beyond what is obvious and present, that's the first lesson. 2, to focus on the larger context. Samne patient baitha hai, sorry, I'm used to this occasional, this Hindi thing, please pardon me. Patient is sitting in front of you, you are saying, oh, I don't hear, I have difficulty in waking up, difficulty, kuch acha nahi lagta, I feel very bad. Your prescription pad is ready. At least try to look beyond that and focus on the larger context. Ghar mein kaun hai? How many people are there at home? Just maybe 5 minutes if you can spend, you will find lots of things. And when, as all good clinicians know, I mean, I don't need to, I'm not trying to be a preacher. My teachers are here, or people I consider teachers, Professor Mohan Isaac, Professor Sudhir Khandelwal, they're all my teachers. Okay, I have got many teachers. So they're all remote, online, distance teachers. As they all know, that those are very important. As Bidhan Roy knew as a chief minister of West Bengal, he was like a god. He was a tremendous. There are stories about him, how he got to the social context of the patient and treated. Okay, I'm not going to. So larger context, that's important for the public mental health. At least give it here. To supplement drug prescribing with quote unquote, I talked about that social prescribing to the extent possible, okay, whatever is possible, little bit, but at least the same. again, when possible, to work with multiple stakeholders and task sharers. Task sharing is extremely important because, as I was telling that the new health minister of Punjab, Dr. Balbir Singh, he just said, Dr. Sahab, hamare paas, he speaks in Punjabi, so he says ki we don't have psychiatrists, we don't have psychologists, we don't have counselor. All we have is 2,000 nursing students, and this is my workforce. You find out some work by which they can be utilized to prevent the drug overdose, because there are too many heroin overdoses happening. So I've promised him that I'll find some way after this talk. I said, sir, I'm starting a talk just now. Can we come back tomorrow and then let's work on this, how to use the task sharing principle by using whatever we have. And that can be in a public mental health thing. I'll have to think, but we'll come up with something. We'll see. So, you know, and there are good people working. So whatever. Another important point that I learned that from the PMH philosophy or the PMH approach is to emphasize mental health in all, with or without mental illness. A person with mental illness it sounds totally atrocious. I know it sounds completely contradictory, but a person with a defined mental illness can also have various degrees or shades, dimension of mental health or mental well-being. On the other hand, a person without a defined mental illness may be mentally unwell. Many of us in our society are like that. Without trying to be political, these days I've become very careful. I actively avoid using political jargon things. It teaches me, the public mental health approach teaches me to be a teacher wherever I can, to my family, to my patients, to my caregivers of the patients, to their families, to a school, to wherever I am, to a media if I can, etc. But along with teacher, to be a student as well, because we need to learn so many things. We didn't know that physical exercise has such a strong connection with prevention of depression, did we? I didn't know that. I'm not ashamed to acknowledge that. Now I know. So we should be students also of the green spaces, how it really helps, opens up parks and walking in a park, actual effect size of more than 1.3, etc., etc. So studies. And finally, to be humble. It's not just to learn that writing venlafaxine is not just, is an important part, but not the only part. There can be other parts in public mental health. As the Alcoholics Anonymous Serenity Prayer says, my most favorite, one of the pieces of poetry, I think, as you know, God, give us the courage to change the things I can, the serenity to accept the things I can't, and the wisdom to know the difference. Critical issues are there, like, as I've already said, this is too broad a term. Some people say everything comes under public mental health. Other than seeing one-to-one patient, you are putting everything there, prevention, promotion, this, that, up to tertiary. So what is left now? You're trying to grab everything, all encompassing. Focus can get blurred. It can get into fight with terms like social psychiatry, community psychiatry, this psychiatry, that psychiatry. Other than strictly biological psychiatry, you are actually putting everything over there. So we need more precise and operational areas of work, agreed. We need relative focus of emphasis needs to be split out, agreed, at different contexts, and a lot of work needs to be done, etc. I won't go into this now because this World Mental Health Report, as many of you would be knowing recently, that the latest one, which shows about that, it gives a lot of focus on public mental health. Chapter 2, if you can read the executive summary, just the heading of chapter 2, is the entire chapter is on public mental health. So this is the one which I wanted to show you. A patient from South Africa says, it's a narrative as they put in that book, and she says, and they've given her a photograph, okay, I mean, and her name also, because she doesn't want to be stigmatized by without the name. So he says, I live with schizophrenia and I have mental well-being. This beautiful writing. So she writes to the ends. Most importantly, she writes the last line, if you can read, I don't know. Most importantly, I have mental well-being. She's on medications, but she says, I'm mentally well. A diagnosis of a mental health condition should never be a precursor to defining mental well-being. Beautiful, beautiful, beautiful sentence. So again, that thing in a more formal manner, that there are two different axes and they're orthogonal. They're orthogonal to each other. They're right angles to each other. Mental well-being and symptoms of mental health conditions or mental illness. They're orthogonal. Ideal is a person who does not have symptom of mental health illness and has a high level of mental well-being. But all four quadrants combinations are possible. And the risks and the protective factors, why I put this in the slides, that many of these, of the risks, for example, and the protective factors are at the public mental health domain. Just for example, read the right-hand pink column for risk. All of these, almost all of these are large-scale factors: climate crisis, poor quality infrastructure, etc. We are talking about climate crisis now that Joshimath is sinking. Sorry, I promise not to talk about politics, but please allow me to say that now that Joshimath is land subsiding, people have become completely homeless. You know what's happening there. Media is not showing you. Go to subaltern media, you'll find out what's happening there. You'll find out what's happening in Doda, in Jammu. Media will not show you there. A particular type of media, you know what I'm talking about. They won't show you there. Find out what's happening with climate crisis and environmental degradation, exactly what's written there, how it is affecting the mental health of an entire population. Escitalopram will not help there. Poverty, okay? Problem is that you tend to become political gradually as you talk about that, but we can remain apolitical because we can still help whatever we can in the thing. These things are well known. I don't need to talk to psychiatrists about these things, that how widespread mental illnesses are, how undertreated they are, you know, the gap. Our own data, of course, our Indian data, we all know NMHS and Atul Ambekar's that drug thing, you know, but we all know about all these things. They're under-resourced. But there are key gaps in public mental health. It's not easy. There's information gap because data is not there. Research is not so much there. There's governance gap because of policies, plans and laws are not there, or misplaced priorities are there. There's resources gap. What is the public health budget this year? 1 week ago on 1st of February. What proportion? Despite we being told that there's an increase in some 2,000 crores, if you please look at the details of it, the only thing which has increased is the insurance supported by the government, which is a good thing. Ayushman Bharat, very good, excellent. But if you really look at other things, they've all been cut. They've actually been cut. And mental health is less than 1% of that minuscule health budget itself. So how are we supposed to, you know, do that, etc. But with this, I think we can still, I want to finish off now with this, you know, with this thing. People at the end of the day, they are lonely, they get isolated, they get cut off, as this program shows. And at an individual level, I wrote one of the editorials a couple of years ago in the World Social Psychiatry. That was when they had UK and Japan had put up a minister of loneliness. You know that there is a post called Minister of Loneliness. So their official post. So I thought that, look at all, that was a Beatles song. Look at all the lonely people. So can we stand up? And now, well, that was a social psychiatry journal. And anyway, nobody reads it probably. I don't know. But yesterday, not yesterday, last month, well, there I talked about macro factors and meso factors and micro, whatever I thought were important, or something that I'm talking about. I won't talk. They're all freely available if you want. Just this is the perspective which has come up, my friends, last month, January 19, in none other than New England Journal of Medicine, the queen, the doyen of hardcore medicine, not psychiatry. Leave alone social psychiatry, bahut dur ki baat hai. So, and this perspective says, it's a wonderful article, 2-page, worth reading, freely available. Social isolation and loneliness as medical issues. People are talking about as medical issues, including mental, obviously, but more than that, medical, because, and they are talking about, because it causes morbidity, mortality. I showed that. They're simply saying things like year framework they have said. E for educate, so that social connection is a part of healthy lifestyle, etc. That it affects risk for illness and death. Assess, how many of us assess, do we ask a simple question that do you feel lonely? In Scotland, when I was practicing there 5 years ago, 4 or 5 years ago, I remember one elderly lady came and she just said, she had huge amount of multiple morbidities, you know, chronic pain is the commonest one. Everybody's on cocodamol and stuff like that, etc. She just said, the doctor, I feel lonely. And honestly, I had no answer to that at that time. Of course, I tried a bit of social prescribing by writing a referral to the social care and etc. But do we even document or even ask about loneliness, social isolation? And then if you can identify somebody who is very seniorly, one of my patients earlier when I was working in Liverpool, that was way back, okay, in 2005 I'm talking about, he told me, I'm going to kill myself. I have 5 cats. He was living alone with 5 cats. He said that when those cats die, then I will kill myself. Very calmly, he said, very calmly, without any emotion. No, he said, I'm not going to kill myself now because I'm living for the cats. What do you say about that? How does a medication reach you, reach in there? Okay. And finally respond, whatever you can, to some extent, at least you can talk a little bit, or can, this is where patching up with NGOs, with other volunteers, with other caring agencies, whatever you have, wherever you have. In Bangalore, we have very good places, but in Northern India, there is very few, whatever, local community resources. Yes, government has to do a lot, but at least we need to have that characteristic. So I'll end it with now saying, what is a follow-on? I promised you that I'll end with the title that we started with. What is a follow-on public offering? We talked about initial public offering, which is done when a stock starts, when a private company goes public. An FPO, follow-on public offer, is the issuance of shares to investors by a company listed on a stock exchange. So it's additional shares. And for people who know, they know a very famous, very recent story with a famous businessman who finally got the FPO and got it cancelled. But the question is that, so who is who? I thought, just for fun, who is who or what here in this FPO that we are talking about? So the same definition, foreign public in the issuance after an earlier IPO, which I thought was the R.G. Kar Medical College presentation. That was initial public offering. And this is the second of the follow-on public offering of shares or tools or resources. Under one heading, you can get it in the Comprehensive Mental Health Action Plan, but you can make up on your own. To investors. Who are the investors? You or us or all of us. So, because I'm sorry, I should have ideally taken a Zoom similar kind of a snapshot and put it right now here live. But since I couldn't do that, I took, interestingly, a cabinet meeting of Boris Johnson, who was the then Prime Minister of the UK. So you can see Boris Johnson speaking at the left-hand top. Anyway, never mind. That's just for joke. We are the investors. We are the people. We are the investors. And we have to apply these stocks. By a company, which, allow me to show this picture. This is our guru, everybody's guru, Professor N.N. Vig, and an elderly picture towards his end, actually. But and in the context, in the background of PGI Chandigarh, as you can see, as a WPA collaborating center, and I thought jokingly listed on a stock exchange. So perhaps WPA is a stock exchange. It's not that I'm trying to, but we need to do something together. And that is where, my friends, I'll end with this. The Diamond Jubilee Conference, 60th year of our department, is coming up in this September 2023. It was started in 1963. So the Diamond Jubilee International Conference on Mental Health, where as a WPA collaborating center, we are talking about, the theme is 14 to 16 September theme is public mental health of the people, by the people, for the people, the famous Abraham Lincoln definition of democracy, as you know, in PGI. Please come, all of you are invited. Please check out. Website will be ready in another week's time, or so, the initial one. But anyway, I have sent it in the EIPS also. Please do come. Let us make it together. We cannot do it without you. Thank you very much. I think I must finish now. Thank you, madam. Thank you, sir. I think I'll stop the screen sharing now and get back.
Thank you so much, sir, for a scintillating presentation. Over to ma'am. Ma'am, over to you.
That was really wonderful. What an inspiring talk. Well, what we learned is to look beyond And of course, along with what we usually do, to have a little bit of social prescribing, going to people, thinking of a larger perspective, so that we just don't look at an individual patient, but probably a community, society at large. And at the same time, to be a teacher and a student, both.
Thank you, madam. You have
I think that was
perfectly summarized everything.
I think that was really inspiring. I'm sure we have an august audience, stalwarts amongst us who have been working in the field of public mental health since many years. Dr. Mohan Isaac is here. Dr. Srivastav is there. Dr. Sudhir Khandelwal is there, and many more. And so I think it will be really nice to get some comments from them. But we do have a few questions in the chat box. Let me see a few. And initially itself, when you began the talk, Dr. Jabbar Hussain has asked, today's media reporting is affecting public mental health. What is your opinion about this? So,
Okay, would you like me to comment? I think Dr. Mohan Isaac is there and he would like to make some comments. He's already very late there in Perth. I think we should let him have so that then he can go off to sleep. I'm feeling very uncomfortable because of him.
No, I will not. I will make my comments after you answer all the questions. People are
Mohan-
here to listen to you, Debashish, not to
Dr.
me.
Mohan Isaac
Please
will
respond
most
to the
likely-
questions.
You will be till the end.
Yes, of course. I will be still there till the end.
Okay, sir. Thank you. Thank you so much. Yeah, media. I'm happy that you're. So I'll just spend 1 minute on that, or maybe 2 minutes. That's a very important area. I mean, one can talk a lot about that. Media can be a friend, and as you all know, media can be a foe as well. There are, for example, there are reporting guidelines on suicide. You know that there are some societies, not all, professional associations have made media reporting, because at times, you know how media hounds those people who have attempted suicide and makes a kind of a story out of it. Every media is after the so-called TRP, as we all know, and for this kind of ratings, people can. That's one example. We have all seen how media has behaved in some of the sensational, quote unquote, drug cases. Again, I cannot name officially, but I think we are all, especially the Indian people, you're very well aware of that, painfully aware of that, what happened, etc. So those are the bad sides, those are the flip sides. Okay. On the other, so there are many other flip sides, but again, as I'm actively trying not to become political, because I will be treading on politics if I go any further. Okay. Yeah. But there are positive sides also. Media, NDTV used to do very good. Well, our dear friend, who unfortunately is no longer, sorry, I'm just missing his name, Dr. Khandelwal would recall immediately, who did the whole series. Huh? The TV series called Mind Matters and things like that.
Avdesh.
Yes.
Sharma.
Yes, of course, yeah. Oh, sorry, it just slipped my. Avdesh, Dr. Avdesh Sharma, years ago, he utilized the media so beautifully, so creatively to generate awareness. And that is, I'm very thankful to the person, Dr. Jabbar, to raise that. Media can be our friend and can be used very effectively for propagating the concepts of public mental health. Thank you.
thank you, Dr. Basu. Dr. Devendra Basera has asked, what is the scope of public mental health in the upcoming era when health services are increasingly becoming private or corporate based, where primary outcome measure is generation of revenue?
Well, I mean, that's something we can't prevent, right? I mean, we cannot say, like the NHS in England to make, or in Australian system to that extent possible, to make still everything government based, because we do not have simply, we are far outsourced by the resources. So private sector is a very important sector, and they do serve. It's not like that they don't do, they do serve. But yes, they are profit driven by definition, etc. What I'm trying to say is that even in the private sector, if we generate the advocacy and the awareness, even there can be some roles of there. And it's not that every private sector person is bad. I'll be the last person to say that. Most of my students are in private sector and they're doing wonderful job, you know. So they are also, they can liaise with some NGOs, with some society fields. They go to various kind of, at least the bigger ones, they are invited to various forums. At times they're in government things also to get to know. People can help in that to an extent. Definitely they can. I think, you see, if we start antagonizing people, public mental health, we can't afford to antagonize. We have to carry everybody along, and including private sector. That's my simple answer.
Yes, I think that's a wonderful approach. There is a comment given by Dr. B.K. Variach, and he says that in Punjab, the buddy system was an example for spreading awareness of substance dependence, however, needed implementation. Similarly, we need to keep learning and teaching, create media awareness, etc. A very relevant comment, according to me. He continues to say that also the campaign for setting up assisted living in Chandigarh is being picked up by some people. An example of NGO, how they are helping public mental health, he has given it. Can we reduce mental stress while going through rapid urbanization? Is a question by Dr. Idris Sheikh.
Urbanization, as we all know, is one of those very well known, not from today, but for last 50 years, is at least, if not more probably. If you think of the original, studies of 1939s and all, Faris and Dunham, etc., then we are talking about nearly 100. That's a very well known factor. Again, it's not. We obviously we cannot say that, okay, let's all go back to the forests. We are not saying that. But within urbanization, if we can help to create some support systems, simply speaking, if there can be green spaces at an environmental level, or if there can be supporting buddy or other systems in there to some extent. In Calcutta, I have seen, for example, where I belong to originally, I mean, I still belong to Calcutta, although I live in Chandigarh. But in Calcutta, in the lakes, we have a beautiful lake, 10 minutes. There, elderly people, they come together every morning and they have laughter club, that thing, which is the laughter thing. They just come. I think more than the laughter, I personally feel is the communication and the cohesion, which helps them a lot. Then they come together, they have a cup of the Bengali type of tea, chota, and then they will do a little bit of a talk and this and that. I think that gives them a tremendous amount of things, which in terms of public mental health, within urbanization and every stress, it can still be. So similar kind of things can be thought about. Yeah.
Yes, absolutely. Then Dr. Yogendra Malik has asked, is public mental health same as community mental health, or just changes the name time to time, like old wine in new bottles?
Okay, that's a good question. As I said, that there is some of the critics would say that what is new in this? This life changing. Yeah, exactly. Old wine in new bottle. No. Public mental health actually is one of the broadest terms which encompasses three components of prevention, promotion, and treatment and care. Okay. And in that, the settings differ. Settings is not only community. Settings can be, yes, community, yes. So community mental health can be seen as a part of public mental health. Okay. But public mental health as an approach, as a philosophy, as a perspective, as a paradigm is broader than community mental health. That's how they are all like Venn diagrams. Okay. So they overlap a lot. And we need more clarity. I would agree with the friend there that we do need, and we need a white paper on that. I think the College of Psychiatry's Royal College, Subodh and Pham Bui, the editor of BJP, British Journal of Psychiatry, they are, and their team, they are working on such kind of clarifications. And it's very important. I agree.
True. I think questions in the chat box are over.
Yeah.
And well, I think we are all keen. Yes,
Dr. Aleem bhai kuch bol rahe hain.
Devashi sir, you talked about the pump handle. What about the Twitter handle? How to use? the role of social media basically now.
Yeah,
Because
I know. That's a good thing.
how to
Next-
engage.
Next time I give a talk on this area, I will cite you and I will add Twitter handle also. I'll definitely, I promise I'll add 2 slides on that. Okay, so very important, very important, very important. I think the first person, Dr. Jabbar, I think, Madam, aapne jo bola tha, he did talk about that social media, etc. So it's similar to that. Twitter handle as a similar symbolic thing of it can be our friend and can be our foe. And it is up to us also to a large extent, I think, to take care of that, how we want to utilize that. I think I'll stop here because I'm just aware of the time and I still want to really hear Dr. Mohan Isaac and if possible, Dr. Khandelwal also. I don't know if he's still there.
Yes,
Sir,
yes,
one-
Dr. Alim.
sir, being a being a devil's advocate, some person is agreeing to you. Now, a person who is joining psychiatry now recently in practice, he says ki whatever you're talking is too much idealistic. Why should I listen to you? Why should I believe in all this? Why should I help in all this? What is the gain to me as a new entrant? I'm already searching for patients and you are talking about all these big fundas.
Right. Good question. And that's the thing which I said in the handle slide. The last one was say that why at all bother about the handle? Let me just treat the cholera. You know, that's one way of looking at it. If you're happy doing that, I cannot stop you from doing that. And my point is that I have to go back to a much more serious and a definite thing there. As human beings, as doctors, we are also agents of the society, and we cannot, I cannot wash my hands off that. I cannot absolve myself of that. I will remain willingly or unwillingly, I will remain an advocate of the society. I will remain. And if I'm not doing my job there, then I'm doing a bad job. How many patients will I treat? Yes, I'll earn enough money. In any case, we are earning good enough money. Let's not fool ourselves. I think we are earning enough money to be comfortable. Okay. How many? Our role as human beings, as citizens, as advocates will have to be there. And there, to some extent, public mental health components or concepts can be utilized.
I think there is one last question in the chat box which has just come, and I think it needs attention. And Dr. Dilip Kumar Verma has asked, role of Babas like Dhirendra Shastri and ashrams in public mental health. Can you comment about that?
Yes, I can very briefly. We are not talking about the Babas who are in behind the bars right now, I suppose. So, we are not talking about Asaram Bapu, for example. I can name them because they are now officially convicted. So I don't see that I'm being politically correct. There are many people, Gurmeet Ram Rahim Singh, who is, while out on bail, is giving public satsangs and all, etc. We are not talking about such Babas who are frauds. We are talking about a large number of very senior, sincere people who can do tremendous good to huge number of people in the society. And they have, madam, they have unthinkable reach. You talk about Baba Gurinder Singh of the, Babaji of the Radha Swami Satsang. My patient gave me English books of Baba Gurinder Singh Chadda in Liverpool. I mean, where I was working in UK. So they can have a very strong, today, right now, allow me 1 second, please. If you can see this book, I've just taken it from my bedside reading table. I have a number of books for the bedside reading table. Can you read this? Ulta ho gaya, I think.
No.
Well, this is Sri
We can see.
Take it.
Yeah, okay.
Intimate note.
An intimate note.
Yes. Yeah. This yesterday, one of my patients have given me. Okay. Now, all I'm saying is that, and I read one of them, how not to, when somebody behaves rudely with you, how to react. And I found it very useful because I usually react very badly when somebody is rude. Okay. They can be a great thing. But of course, you have to choose it rightly. You have to choose it wisely. You don't choose a Ram Rahim Singh. You don't choose an Asaram Bapu. You don't choose a Nityananda. I have given you 3 names from 3 different places. No, but there are so many good. We have Swami Vivekananda. We have, so the answer is very clear. We need them. We need spirituality in this public mental health can be tremendously bolstered by using. Yes.
Thank you so much. Now I think
Yeah.
Dr. Mohan Isaac for your comment.
Okay, thank you very much. I'm sure everybody who listened to this program would agree that this was an excellent talk on a topic, as Basu himself said, not very interesting. It is not about the latest neuroimaging findings on schizophrenia or bipolar disorder. It is not about the new molecule which might have maybe few percent more effective than a placebo in an antidepressant treatment, etc. So he warned us. But let me tell you, it was not at all boring. It was most interesting. I want to make 2 or 3 comments. Basu said that he is grieving through the loss of his pet. His dog is not there. The grief was not evident. I'm sure he's going through grief, but the public lecture and the preparation must have helped him to get over the grief.
Yeah.
Of course, he missed his walk, but then he said that in the talk, I mean, just to tell you that I listened to everything. He said that a minimum 2.5 hours per week is okay. So if he missed the evening walk for today's talk, that is well worth it, because a lot of people have learned from your talk. Now, the point I wanted to mention is, in a very interesting way, he has given the broader meaning of public health. Of course, he used the John Snow's water pump and handle example, but it was probably, if there are a lot of young people listening, and I would suggest that you should give this lecture to as many audiences as possible in medical colleges, not necessarily to psychiatrists, because all this is, although from the perspective of psychiatry, relevant for all doctors. So he gave an excellent way of giving the second connotation of public health. Also using, I mean, of course, I don't know very much about share market and all that. I learned a little bit about the terminology. That was very good. Now, using the pump, he gave an example. See, the question was asked, Dr. Aleem Siddiqui asked what a young person would ask. My response would be, although I have never been in private practice, I have always worked in a university or public sector. My response is, what Dr. Basu has said doesn't take a lot of time. Along with your drug prescribing, if you have the mindset, you can do also the social prescribing. It doesn't take hell of a long time to tell them, okay, every day you must walk, and that will, of course, decrease your depression, etc. My guess is, I mean, I'm sure I'm happy if somebody wants to do a controlled trial. If a young doctor practices what Dr. Basu said today, without extra time, etc., he will ultimately wait for a year or something. He will ultimately have more patients than the person who doesn't do the social prescribing.
Absolutely.
So if a young person asks Halim, this is what I would answer. And I would think that it can also be proved if somebody does a kind of a randomized controlled trial about young psychiatrists in private practice, what works best. Because essentially what he said is not rocket science. It's all very, very simple things, you know. The example of activity. He talked about the New England Journal of Medicine, issue of loneliness, a social connectedness, etc. It doesn't take a long time to give a lecture. It takes only little extra time to do that. That's my second point. But I think for me and for psychiatrists who do not want to take the public health message very seriously now, I think the important message is about the recovery-oriented care for people with chronic severe mental disorder. Today, at least in all developed countries, no mental health services without recovery orientation. Whether you do anything or not, those key words have to be there. It is on documents, it is there everywhere. Now, what is this recovery? When at a basic level, can schizophrenia be cured? No. Will the disability be all gone away? No. But he gave in a very, very, very nice way, including quoting from the latest World Health Report. Now, with recovery is all about having a continuous illness from which you may never recover, but having a certain quality of life, a certain sense of well-being. I think that point came across. So even if somebody, a young psychiatrist, doesn't want to do the social prescribing and the physical exercises, if he has learned from today's talk the recovery orientation in managing people with chronic severe mental disorders. I think that would be worthwhile. And the last point is, he did mention about the pump, the handle, what he was doing. He gave some examples, etc. One example particularly touched me, and that is the Helicobacter pylori. Why did it touch me? I work in the hospital, Fremantle Hospital, where Barry Marshall, who has been a colleague, is a Nobel laureate. Everybody knows about
Yeah,
that.
yeah, yeah.
I work in the Fremantle Hospital, in the same floor where he famously took a broth, a beaker containing broth, because his papers, including the Australian Gastroenterology Society, said was below it was in the lowest 10% as far as quality was concerned. From 81 to 83, he struggled. They said, all the gastroenterologists in the world said this is foolish. Peptic ulcer, and you're saying bacteria? How will the bacteria survive in the acidic environment, etc.? So he had to wait for 2-3 years, ultimately demonstrate, do a gastroscopy before bring this, develop, peptic ulcer, etc. And that occurred in Fremantle Hospital, where I work every day. And Barry Marshall, of course, is a very distinguished colleague, the only Nobel laureate among our faculty. So that Vasu mentioning about that. The point he was trying to make is, again, it is not rocket science. Is the handle high? Maybe we'll have to reach that. Is the handle too long? The example of Jon Snow's, water pump handle has been excellent. So thank you very much. It has been a very, very interesting talk. And back to the president.
Thank you so much for those beautiful comments, which were so insightful. And yes, it is so simple to do it, is the message that you are giving us. And I think that's what we would like to know, that yes, it is simple to do it. Dr. Aleem, over to you.
Thank you, ma'am. If Amrit allows, one last line. Sir, do you miss power outages?
I know, I read that.
Because
Kya? What?
you miss power outages, because 20 years back, 30 years back, when there were power outages, we used to meet with relatives, neighbors, everyone was on the street. There were no inverters or generators. So I think this laughter club that you told, that brought back assembly. So this it's a good gathering.
You have WhatsApp groups now. You have WhatsApp groups now.
Oh, yeah, WhatsApp. Anyway, yeah.
Thank you.
Chalo, I think.
Tufan sir, over to you.
Thank
Tufan,
you.
sir.
Thank you, Dr. Devasius, for a excellent talk. Actually, I am a promoter of community mental health, but now I find you have given 3 messages. Community psychiatry is not only psychiatry for the community, in the community. It is public mental health. Public mental health, other diseases, everything is correlated. A few days ago, I read UN news. In 80 countries, 350 million people are under food shortage. How can you plan for any project, anything with these people? So there has to be outreach for them. And second, I take a message, at least for me, it is not only a localized issue, it is a global issue. A totally global issue, so one must have a global perspective. And third, it is easy to incorporate into one's practice, regular practice. For example, advising about recreation, advising about to follow the old religious script, or advising to do exercise, which I usually do, will have some impact. It's not as a big thing that he has advised. He has shown a new way. And the last thing is that this should reach everyone, as Dr. Mohan Ajak told. It should reach every young psychiatrist, that you don't have to invest more. It may not help you in your positioning of yours as a psychiatrist, but definitely it is required. And as a younger psychiatrist who is going to shoulder the burden of the future, you have to do it. And thank you very much. So much of things in a short span of time. You could have taken more time, and we will call you again. Thank you,
sir. Thank you, madam. Thank you, everybody.
Amrit, over to you.
Over
Thanks.
to Amrit.
Thank you.
Sir, 1 minute, last comments from me. So thank you so much. The take home message from me is that I am not a bad practitioner because I prescribe, to my patients instead of with medicines. I also talk about the best gym around their locality, where I can connect them to a good lawn tennis club, a coach, a personal trainer. I do a lot of things. So I always felt that maybe I'm somebody who is a loner. But listening to your talk, I felt very good. The second take home point for me is psychiatrists should become politicians also, because policy is the most important thing. I think that's my take home message. Is somewhere we need to be in the administration, and the problem is most of the time the private partners are not recognized, sir. It's only a PGI or a NIMHANS is overburdened, and sometimes when we are overburdened with a lot of things, sometimes it gets diluted. So we should become politicians or policy changers or policy makers. Whatever take home message is this, we need to be at the top to get the changes moving on. So thank you so much, sir. Thank you, Janvi madam. You were wonderful as a chairperson.
Yeah.
We missed our chairperson, but not
Yes.
in the real sense. So thank you everybody. It was a
Okay.
3-week break. And Mon sir, thank you for joining all the way from Australia. You came to Bhubaneswar also. So lucky to have you all. So thank you. Good night.
And next time we will all see you in Chandigarh.
Sure.
Please
Yes.
try to make a date for Chandigarh, 14 to 16 September.
Sir, we'll come, sir. Assurances from this.
We'll be
My-
there.
Definitely.
Thank you.
Thank you.
Okay,
Thank
bye.
you.
So,
Namaste.
Thank you, ma'am.
Thank you.
Thank you,
you,
sir.
everybody.
Closing the
Thank you,
meeting.
everybody.
Now, sir.
Thank you. Bye.